The UMKC Healthcare Institute for Innovations in Quality. This is the home for where we have the KCQBSE Forum. So thank you to everyone who's here today for our forum. Today we are talking about caregiving trends, burdens, and breakthroughs. So thank you for being with us today. I'm going to start with just a very high level overview of the Institute so you can understand a little bit more about who we are, what we do, before I hand it off to our very experienced and illustrious speakers for today. My name is Stacy Farr. Lovely to meet you all. So a little bit about Healthcare Institute for Innovations in Quality. We have this vision of Kansas City delivering the highest value, most equitable healthcare in the nation. And our mission is really to catalyze and facilitate multi-stakeholder collaborations to improve the quality and value of healthcare in the Kansas City region. We're supported with by a number of our partners, including BioNexus KC, UMKC, Mizzou's Next Gen Precision Health Institute, and Frontiers Clinical and Translational Science Institute, or CTSI. We are all well aware of health systems currently struggling to find ways to improve the quality and value of healthcare, operating under shifting payment models where there's currently, we currently operate in the landscape of delivering, fee-for-service medicine, right, where we deliver higher cost and, sometimes at considerable quality, but really volume driven. And we all know that we need to move to really improved quality at reduced cost and really getting to value-driven healthcare, but really no one really knows how to do that. And so here with IIQ, we've created this regional strategy where we're bringing together a number of interorganizational partners, including those including stakeholder types of providers, researchers, purchasers, payers, community organizations, and patients to really work on finding ways to innovate and tackle the U.S. changing payment and healthcare delivery landscape. And we're really evolving. Many hospitals or departments are learning health systems, right? They find ways, they learn what they're doing, they iteratively improve. And what we're really trying to do is evolve to a learning healthcare network or a learning healthcare community where we work across organizations to implement evidence into care and use it to learn from one another and iteratively improve as a community to optimize outcomes. We have three main strategies by which we accomplish our vision mission. These are regional quality improvement activities or projects. This is a map of Kansas City. Our two current projects are the opioid management project, as well as the transitions of care for heart failure project. And these involve a number of hospitals that are all working with IIQ, and we're working with them to implement evidence into their routine care and measure outcomes. Our second kind of leg of the stool is training and education. Our original flagship program is TIARA, which is training and implementation, actionable research approaches. And this is really with the recognized need that in order to do regional quality improvement or to do quality improvement at all, we really have to understand how, the science of how to change care. And this is really the field of implementation science in which we're really growing. We're also expanding that in other areas with coursework and more advanced training. So there's more to come on that. We also have, as you're all here today, the KCQBIC Forum, our dissemination and engagement flagship program, where we convene a number of you wonderful stakeholders together so that we can talk about common problems in our region and come up with creative, innovative solutions and work together. So just reminding you all, we have these two main projects, our opioid management project, KC EPIC, as well as transitions of care for heart failure. And with transitions of care for heart failure, we have a number of different interventions that we are implementing in our community across different sectors of we call this the heart failure carousel here, from inpatient through being in the hospital, transitioning home, and work and in the home. So, but we are all here today for the KCQBIC Forum. Today is October 20th, and we are very excited to talk about caregiving trends, burdens, and breakthroughs. This is a topic that's very near and dear to my heart and was actually the subject of my dissertation, caregiving. And I just, there's so much in this space, and I really can't wait to hear from our wonderful speakers. You can also join us next month on improving transitions of care for heart failure to hear an update on our regional QI project. And if you are not yet registered to receive notifications, there's information there, and we'll be releasing our 2023 schedule very soon. So here is our agenda for today. And with this, I will now turn it over to our first presenter, who is Jonathan Davis, founder and CEO of Trulata, who will be bringing kind of a researcher perspective on designing and implementing digital interventions to activate the family caregiver. So the floor is yours, Jonathan.
All right. Well, thank you very much. Thanks for that intro, Stacy and Pat, for inviting me. Really excited to be here among a great speakers lineup. I know this will be a really interesting discussion. So I'm going to kick it off. Today, we're talking about designing and implementing digital interventions to activate the family caregiver. Again, my name is Jonathan Davis. I'm the founder of Tralta. I'll tell you a little bit about who we are and what we do, but mostly want to focus on the research and evidence that we've sort of uncovered through our work with family caregivers. But by way of background, about 4 or 5 years ago, I was previously working with education companies for healthcare providers. So they were training and certifying and doing continuing ed. And we realized there was great content, great methodologies out there for supporting really our aging population at home, and none of the content was available to the families who needed it most. So we built a family caregiver education and support platform. And KC, I'm actually located in Ottawa, Ontario, Canada, although most of our partners are in the US, and KC is kind of close to my heart as in Kansas City, the CBO MARC, the Mid-America Regional Council, and under James Stowe's leadership, was one of our very early believers and pilot partners. And I think that's how Pat found me and us. And I'm really excited to share sort of what we do, and I'm excited to be here on the panel today. So we'll start with a bit of a user story so we can really understand how we support these family caregivers and how, we really believe that family caregivers can improve outcomes. In the photo here is Christine and her mom. Christine is 47. She's caring for her mom with dementia who had a fall and hip replacement. And Nancy, who's Christine's care manager, was evaluating post-discharge options. Christine had many, many questions and about how to support her mom's new physical needs at home, along with cognitive challenges. So Nancy invited Christine to Tralta. So she's offered an invitation to the platform. She says, okay, I'm gonna help create a personalized learning plan for Christine, which includes brain health, mobility, pain management to keep her mom comfortable and healthy at home. And Christine's one of our power users. So she logs in 17 times, she completes a bunch of badges. And then we talk to Christine a lot about how these skills are helping her manage care at home. And, she uses Tralta, the skills that she learns on Tralta almost daily, and that it helps extend aging in place. So set the scene with a bit of a story of sort of an example of a caregiver that we work with. And a flexible caregiver engagement. And so what is Tralta? We're a flexible caregiver engagement platform to help families build skills, increase confidence, and feel less alone. So we've offered professional level training adapted for the untrained family caregiver with skill-based content across care competencies. It's an on-demand, personalized educational intervention, so it can be accessed 24/7 from any device. The journey can be caregiver-led, or their case manager. So for example, someone at MARC could recommend the content to the caregiver. And so they're seeing what's most important to them. We'll ask them 3 like Netflix style questions up front, and they get a personalized learning journey because they're caring for someone with heart health transitioning home, as Stacy's kind of other program that you mentioned. It's really interactive content. We help caregivers work through scenarios. If they're busy and they're making dinner, then they don't want to read, they can press play and they can listen to the content in Spanish or in English. And we share a lot of stories. We have a lot of social features. Really, it's all about building skills, increasing confidence, and feeling less alone. So that's kind of an overview of what we do as a platform. And I'll also show sort of what it looks like. Just a screenshot so everyone gets a sense before we launch into the research. We built Tralta for older eyes. It's for family caregivers, really easy to use, easy to navigate, 5 to 10 minute modules. It's available on mobile and on desktop. Most of our users use it on the computer, and about 45% of our users are age 60 plus. So that's, sorry, I checked the chat box to make sure there's no questions, pop that open. And then as you can see in the front, there is print material as well. So some of our users are rural, maybe they're not totally connected. We try to get folks to go to the library if they want to use Tralta. We try to get them online, but for sure we offer print alternatives for rural caregivers. So we support caregivers with critical skills across a range of complex conditions. We really want to meet families where they are with just-in-time learning. So, we started with serving caregivers who are caring for loved ones with Alzheimer's, dementia, or related dementia, or some type of cognitive decline. And really that started because we found that behavioral symptoms were the most triggering. It was like, hey, sundowning in the evening is really, really hard for the caregiver to manage, or, there are periods of agitation and anger or apathy. My husband won't go for a walk with me anymore. My mom's not listening. She's angry at me. And so it was responding to behavioral symptoms where caregivers were at a total loss and they were going to the doctor, or they were starting to think about, transitioning loved ones. And so that's kind of how we started, but it really grew as we serve a number of CBOs, we serve health plans, we serve providers. And so it's everything from documents and decision-making about planning for the future, asking your caregiver or asking your healthcare provider or doctor the right questions. And then it's a ton about promoting caregiver wellness and resilience. We know that it's so important that caregivers manage their own burnout. So key competencies, a range of conditions, because we serve some MCOs and Medicaid partners, as well as CBOs that go across the lifespan, adults with IDD, other sort of caregiving situations that are beyond just aging, Alzheimer's or dementia are now in the purview. And, on the right there, it is micro-learning, multiple modalities. We do everything in Spanish, ADA compliant. We have many government contracts, so we definitely say compliant with accessibility guidelines. We do a lot of diversity inclusion, very strict guidelines there, and everything's expert-led and developed by licensed professionals. So to get to some of the research that we do, what we're obsessed with as an organization is understanding how informal or family caregivers learn. And really, like I said at the beginning, it's build skills, improve confidence, and feel less alone. And those are sort of the big pillars around our research and our product and how we build. So there's a few insights that we've discovered, and I want to share with this crowd as sort of a bit more of a research, as a research sharing findings and insights. The first one we came to as we talk to our caregivers and users every day, and just for a sense of scope, there's about 27 states where Trulta is available to some or all of the state. And in the past 30 days, about 11,000 modules were viewed on Trulta. So we're starting to get a bit of a sample size where we really think there aren't a lot of education programs that are speaking to this many caregivers and intentionally building skills. So, the first big insight is that the family caregivers come to us with a specific problem or situation in mind. And so scannability, searchability, and discoverability are so important, because if we're not bringing caregivers to a valuable resource, if they're in Stacy's care transition program and pain management after surgery is really, really important, we need to get them there quickly, or they're going to bounce from the portal. They're going to sort of not find what they need. It's frustrating. They're already inundated with information, overwhelmed, transitioning to a different care situation. So scannability, searchability, discoverability is so important, because the caregiver has a specific problem and they're not there to sort of browse recreationally, and not the profile that has time for that. We also know that caregivers have very unique learning preferences. So we want it to be very, very self-directed without a linear path. So if you want to listen to a quick podcast, if you'd rather download a tip sheet. So for example, with our caregivers of loved ones with Alzheimer's and dementia, the personal care tasks, hygiene, showering is a particular challenge. A lot of people, Alzheimer's, cognitive decline, dementia, don't want to shower. And so, there's tip sheets for how to create a routine and how to some ideas and hacks that we've learned from caregivers, how what's worked in the past to get their loved one. So a caregiver might just want to download a tip sheet. They might want to run through the scenario, how to have a difficult conversation when you have to tell mom or dad that they have to hang up the keys, no more driving. How do you have that conversation and they can run through an interactive scenario? Oh, you say this and they might react this way. So different, unique learning preferences, really important. So we design for all of those different perspectives. The third kind of big insight is that the content must be actionable. Since the beginning, if we give, it's not a kind of nice caregiver blog post, it's got learning objectives, it's interactive problem-solving scenarios so that the caregivers can learn something different, learn to do something new, and then knowledge checks and quizzes, and we try to reinforce the learning as we go. We want it to be very, very actionable for this family caregiver. And then lastly, caregivers have difficulty applying the skills to new situations. And so we really break down these toolkits. And I'm showing you the toolkits on the right-hand side of the page, 3 to 5 different skills across different situations. And by breaking it down into this really kind of modular toolkit is kind of our methodology based on everything we've learned about how caregivers learn for really getting the skills, the confidence, and the feeling that these caregivers will less someone. I think many people on this call would probably know and agree that what's so important about getting these caregiver initiatives and programs implemented is demonstrating the impact. That's how you get sustained funding. That's how you really improve outcomes. You have to have the evidence. And I know that's not news to this group. I always found it a challenge since starting, this platform maybe 4 years ago, was that the caregiver's impact is always indirect. Right? The caregiver is helping the loved one, then that patient maybe, demonstrates high outcomes, but the really important impact that, we want all of our stakeholders also looking at is the impact on the caregiver themselves, and then the impact on maybe the patient, loved one, or member that they're caring for. So we look at those two outcomes separately. If we talk about caregiver impact, are we increasing confidence and engaging caregivers meaningfully? So we want our caregivers to say that after they've done our platform, and this is, we do clinical research. This is at the University of Florida, so large academic health center. 88% said, yeah, Tralta helped them feel more confident. They're likely to recommend it. And we even asked them, hey, does it improve, if your health plan offered this, would it improve the quality, or how would you feel? Or does your health plan offer caregiver resources? Because we really want to engage these stakeholders. And so, a lot of these caregivers are sort of either don't know if they're able to access resources through their health plan, but they certainly do want those resources. And then are we impacting the care recipient, how the care is provided? Because if we can demonstrate that, we can improve outcomes through some of these caregiver programs, we're going to get more support for caregivers. And we're going to be pounding the table to get more support for caregivers. So did Tralta or a program, a caregiver intervention, help you keep your loved one at home longer, reduce your unnecessary ED visits, make you, we even asked them how their level of distress and self-reported severity of different symptoms are, because we really, really want to see impact across both the caregiver and that loved one that they're caring for. So that's the evidence. I hope I didn't go too quickly. I tried to I just stayed in my 14 minutes. So thank you all very much for listening. I look forward to any questions. Feel free to put them in the chat, and my contact info, my email's on there. So if you'd like to reach out and have a chat, I'm always game.
You were perfect.
That was great. Thank you so much, Jonathan. It's really interesting to hear, and I love seeing some of the outcomes. I'd love to review the slides later and look at those again. That's great. Very important work. So with that, we will now turn to our next speaker, set of speakers. We have a pair. We have Mariana Ramirez, who's the director of Juntos Center for Advancing Latino Health at the University of Kansas Medical Center and co-director of Juntos for Brain Health, as well as Dr. Jamie Perales Bouchalt, who is assistant professor and with the KU Alzheimer's Disease Research Center and co-director of the Juntos for Brain Health. And they'll be providing a hospital provider perspective on feasibility, acceptability, and preliminary efficacy of Quietext, a text message intervention to support Latino dementia family caregivers. So very interesting. Can't wait to hear it. And also from a group that was my alma mater. I worked over in the KU-ADC for a number of years. But anyway, aside, so now everyone knows that. Well, the floor is yours. Thank you so much.
Thank you. Are you able to see our screen?
Yes.
Yeah, I think it's on presentation, well, not presentation mode, but just
Yeah.
the little slides are on the left.
Go, Jaime.
There you go.
Well, thank you again for having us. Jaime and I are going to talk about Cuida Text or Care Text now. It's an intervention for Latinos, and it's an intervention that can be used anywhere, anytime. We're going to tell you a little bit about why. This is our outline. So we all know that dementia has a devastating impact on those who have the condition, but also on their caregivers. The persons who get the condition, dementia is one of the leading causes for mortality and for disability. And then the persons who are caring for them, they're not only seeing their loved one with a decreased cognitive.
Mariana, may I interrupt just for a split second? Are you able to make your slide larger?
Attention code 13 code.
No, I'm sorry.
Okay. Okay.
Is it too small?
It's a little small, but keep going. Don't we are fine. We're fine.
So you're not seeing like full size?
We can see the left side. I can see the left side rather well. The small print under your graph is difficult to see.
I see what you're saying. Okay, we can read it to you. So because the loved ones of caregivers, those who are experiencing dementia, are losing their cognitive function, they're not able to do things that they were able to do before. And then the caregiver also has an impact in their physical, their mental health, and also it gets reflected on their finances. Caregivers tend to have more stress, more physical symptoms, more medication use, and less antibody responses, all of this related to that stress. About half of them are experience anxiety, and between 30 and 40% of them also experience depression. And then when we compare them to other caregivers for other conditions, they are more likely to have more unmet needs, talking about their financial needs. So why focusing on Latino caregivers? Well, Latinos have a higher probability of becoming informal caregivers, and this is for several reasons, right? To start with, about 1.5, Latinos are more likely to have Alzheimer's and dementia, about 1.5 more likely than non-Latino whites. They also tend to have less access to formal care. And there's also a cultural component that we tend to care for our elders in our family, and in general we tend to take care of our extended family members without placing them in external sites. Also, higher levels of caregiver depression and poor physical health. If you can see on the graph on your right hand side, almost every symptom of people with dementia, of Latinos with dementia, is higher compared to non-Latino whites. They also have higher prevalence and severity of behavioral symptoms, and they have lower access to caregiver support. Again, we talked about income before. The income for Latinos is generally lower than it is for the non-white population. So this presents access barriers to access caregiver support. So why focus on Latino caregivers? Again, there are plenty of interventions that have been developed to treat stress for caregivers, for example, but very few of them have actually been tested with Latinos, and even less of them have been developed for Latinos. About 75% of the studies that do report on race and ethnicity, they show mixed results for race and ethnicities, and this jeopardizes the generalizability of the studies. And if we continue to ignore the need to culturally and linguistically tailor the interventions for Latinos, we're probably contributing to widening these disparities. Some of the barriers that Latinos experience to access caregiving interventions include, for example, time constraints. We have people who don't have PTO. Many Latinos, for different reasons, including immigration status, don't get PTO. So that is a constraint to access an intervention. Some of them rely on public transportation, and this is, as we know in the US, it is not always a reliable option. Again, income level to afford interventions, and most interventions are in English, but about half of Latinos in the US prefer to speak Spanish or only speak Spanish. So this is a very important barrier, along with cultural barriers that are not taken into account. We know that text messaging works very well with Latinos. We have there's a strong literature that demonstrates that. And we also know that almost everybody has a cell phone, right? Like you can see in the graphic, the cell phone ownership is very high across populations. In particular for Latinos, that's about 96%. And then you can see that almost everybody uses their cell phone for text messaging. In Latinos, that's very high. The highest, 87% of Latinos use their cell phone to testing, compared to using the cell phone to access internet or video. Texting is considerably high. So it's a vehicle that has a lot of potential to deliver health interventions. Another advantage is that when we send the intervention, we develop the text messages, and then we schedule them at the same time, the same message. So we get a lot of fidelity on the intervention that everybody is receiving. We know they are effective. Text interventions have demonstrated to be effective in other fields, including weight management and smoking cessation. They can be accessed anywhere and anytime, addressing many of the barriers that we talked about, how Latinos cannot access treatment because of those barriers. That with a text message, they can. It is low cost. When we're doing this, the number of people that can get into the program and can be follow-up is way bigger than we can do with one counselor. So this reduces the cost of implementation. And even though the messages there are libraries and they're scheduled, and we talked about fidelity, they can also be personalized. So people can access to the libraries of the messages that they need and personalize intervention to what they are needing. They're private. Only the person receiving the intervention gets access to that information. They can decide to share it with other caregivers as well. And we know that text messaging is very engaging for Latinos, and they are one of the highest users of mobile technology in general. Now I'm going to pass it to Jaime.
All right, thank you, Mariana, and thank you everyone for being here, for inviting me. Given everything that Mariana said, that informed the development of the first text message intervention for dementia caregiver support anywhere in the United States, not just in the United States, not just for Latinos, but anywhere in the world. That's called Cuida Text. What we're presenting today is we're testing the feasibility of this intervention. To the left, you can see the model that we are using to develop this intervention. It's an NIH developed model to develop and test behavioral interventions in general. We're on stage 1, which is the generation of the intervention, so the creation and the refinement. So the outcomes are going to be feasibility, acceptability, and preliminary efficacy. And as you can see on the inside, the green square is what we did on year 1. This is an NIH grant, by the way, and R21. And on year 1, we basically, all these six squares, what we can summarize them into, we got the best from the literature with the evidence base, and we got the best from dementia caregivers, Latino dementia caregivers that we met with in working groups, and experts in Latino health, dementia experts, etc., to develop and refine these text messages. On AIM 2, which is what we're going to present now, is the pilot testing or feasibility testing of this intervention among 24 Latino caregivers. Next one, please. So study design, it's a one-arm pre and post-intervention trial. So basically everyone goes through the same intervention, which is Quita text, okay? There's no control group because it's a pilot study. And we do assessments at baseline and at 6 months and see how things change and basically ask what their thoughts are about Quita text, satisfaction, and so on. I'll talk about this very soon. 6 months of intervention. The intervention is bilingual, culturally tailored. The cool thing about this is not that we are adapting interventions. The first intervention developed is specifically for Latinos. It's not that we're adapting, it's we created directly for Latinos, the first ones. There's two-way communication. So we send participants, as like Mariana mentioned, and I'll explain that later, text messages every day, but they can also reply to us. So there's that bi-directionality. We enrolled 24 participants, most of them, as you can see, women, 83%, half of them US born. We had a lot of other people that are born in Mexico and other Latin American countries. Most of them, 75%, were adult children of people with dementia. And we had a high percentage of people whose family member with dementia was uninsured, basically almost a third. Also, the caregivers, many of them were uninsured, but they mostly had private insurance. Let me see. To participate, they had to speak either English or Spanish and provide in-person caregiving to a relative with dementia. And the outcomes, I already mentioned them, so we can go ahead to the next one. A little more in-depth information about this intervention. We have 3 ways to text the participants, okay? Number 1, we call daily automatic text messages. And these are, at the very beginning, they get 3 per day. And then as the month goes on, we taper down to 1 per day at the end of the month. And then from then to the end of the intervention, 6 months, they just receive 1 per day. We got from our working groups of caregivers that they didn't want more in case we burden them. So we want to be really careful how many messages we send them per day to take care of that. These messages help them care for themselves and their loved ones. And I will talk a little more about this. Then we had the keyword-driven text messages. So each person has different needs, and it's very hard to come up with something structured on what needs people are going to have. So the daily automatic ones are the core messages, but if they want any specific help on any topic, they can send a specific keyword, and you can see the keywords on the right? If they want more education, they send the word education. If they want to learn about relaxation for the caregiver, they send the word relax. If they want to learn about how to talk to their loved one, they send the word patient, for example. And there's all those words that they can send. Every time they send one, they receive a message specifically to help them with that topic. So on demand, which is the first level of tailoring. The second level of tailoring is the live chat text messages. And so people can text you any text message they want. They can thank you for the message. They can ask for, can you help me find a geriatrician in my region? And we have a trained person on the other side of the screen that will reply to you during working hours. So we have those 2 levels, and this one allows for more flexibility. The only thing is the keyword one, you can set at any time and you receive automatically the message instantly. The other one, it has to be during working hours that the person will reply to you, but you can also send it at any time. And then at the very beginning, we give them a booklet. It's very short, very pictorial. We developed it with these working groups to tell them about why we do this project and how it works. They really don't need it, but we heard that some people might want to, go a little faster, and the people are curious, so we created it just in case. Next one, please. These are the first set of results, feasibility and acceptability. We recruited during 2 months, and which is actually a very short time for a Latino population, I have to say. The enrollment was in only 20 days, so it was very fast. Many people wanted to participate, given how easy it was to participate. Everything was remote, especially in a time, during the first half of the COVID pandemic. So there was a lot of need. And then retention rate, we retained 21 out of 24, that's 88%. 2 people experienced technical issues. They were very minimal. One of them didn't have internet, so we sent some links to videos, and she couldn't open that, but she could read any other message. And then there's another person who lost the phone for 1 day. The next day they changed it, but they couldn't go back to the history of messages. They would still receive the text message. So as I mentioned, very small, minimal issues. And if they wanted more messages, they could have asked us for them. So not a big problem. Nobody discontinued the program. The average text per person was 77 during 6 months. So 77 each, approximately. Obviously, some people more, some people less. 92% of the people of the caregivers sent at least one message, and then 86% said they read most messages thoroughly. On the right, basically, we have the or acceptability questions that range from 1, which is very low, to 4, which is very high, and everything was between 3.5 and 4, all the averages. So basically, most people thought that Cuida was very helpful in understanding dementia, to help them understand dementia, very much helped themselves as caregivers, very much helped their loved ones as people with dementia, and they were very satisfied with Cuida. Next one, please. In this one, what we're showing is the preliminary efficacy outcomes. For the caregiver specifically, we actually also included some for the person with dementia through proxy, responded by the caregiver. But basically, we were able to move the needle in reducing caregiver depression, caregiver strain, caregiver burden, even though this one was not statistically significant, but we just had a very small n. Still, the other ones were all statistically significant. And then we increased caregiver knowledge, dementia knowledge, and caregiver competence. So their sense of how efficacious they are at caring for their loved ones and themselves. We don't include this here, but we were also able to reduce in a statistically significant way the behavioral symptoms of the people with dementia. Next one, please. Like all studies, there's limitations. We did not randomize, and therefore we did not test the feasibility of randomization. That will be important in our next study where we assess the efficacy. We included very few men. This is common in studies in general, especially with Latino research, and we need to do a better job always with this. We mostly recruit people from the Midwest, but we also have people from California, Texas, Florida, etc. But given that we're located in Kansas City, there's a bias there. Conclusions that these results show that Cuida is the design is feasible, the intervention is highly acceptable, and together with the preliminary efficacy outcomes, it sets the stage perfectly for the next study that we already applied to. We're actually about to get it reviewed by the NIH very soon, in which we want to recruit 150 approximately Latinos in a randomized controlled trial for Cuida. So people will be receiving either Cuida now or Cuida in 6 months, and we'll be comparing those two groups, the efficacy of the intervention. Next one, please. We have other 2 studies in case anyone is interested in spreading the word. We have one big study again nationally that's called Alianza Latina, and it's basically like Cuida plus monthly phone calls to help assess unmet needs and address them. And then we also have the adapted Cuida that we created for Latinos. We've adapted it to other communities, namely people from rural backgrounds, and African Americans as well. and we want to deploy it among 150 family caregivers in Cass, Clay, Jackson, Platte, and Ray counties. This will not be research. This is just service that we provide at KU Medical Center, completely free. Again, anyone of any ethnic and racial background can participate. And again, it's fully remote, it's free, and it's also 6 months. Very simple, basically the same as Queetatex with some adaptations that we've conducted in working groups with these communities that I mentioned earlier. So please spread the word. And we just wanted to thank everyone that's listed here. First of all of you, but obviously also our team, the NIH, the participants, and the funders, et cetera, et cetera. Thank you so much.
Thank you so much. That was really wonderful to see the work you guys have done, and I wish you the best of luck and moving forward as well. So thank you. And just a reminder to anyone, you definitely feel free to use the chat, put any questions, comments, or anything you have for any of our speakers in the chat, and we will either discuss as we go in the chat, but we will also have a discussion Q&A portion at the end. So just wanted to remind everyone of that. So next up, we will be hearing from Lacey Bovin, who is the Regional Administrator for Region 7, the Administration for Community Living with the U.S. Department of Health and Human Services, on a policy perspective, particularly an update from the National Caregiver Strategy. So we're delighted to have you, Lacey, and the floor is yours.
Great, thank you. I almost forgot to unmute myself. All right. So thanks for having me. You know, it's such an honor to share the great work that is being supported at the federal level by the Administration for Community Living. You know, support for caregivers is really gaining some serious momentum across the country. Of course, that's exacerbated by COVID, but it's always been a priority at our agency. And building a caregiving infrastructure is not only part of our agency, but part of the larger vision of the Department for Health and Human Services. And our agency takes that a step further to advocate and ensure inclusion of both paid and unpaid caregivers. So there's just a few things I wanted to tell you. You know, each year, around 53 million people provide a broad range of assistance to support the health, quality of life, and independence of a person close to them who needs assistance as they age, or either that's due to a disability or chronic health condition. And then another 2.7 million are grandparents raising grandchildren. And then we have an unknown number of other relative caregivers that open their arms and their homes each year to millions of children who cannot remain at home with their parents. Millions of older adults and people with disabilities would not be able to live in their communities without this essential support. And replacing that with paid services would cost right now an estimated $470 billion every year. So the RAISE Act which is the Recognize, Assist, Include, Support, and Engage, is a piece of legislation that's sort of leading the way in shaping our work on the priority. It became a law in January of 2018, and it directs the Secretary of Health and Human Services to develop a national family caregiving strategy. And that strategy will identify actions that communities, providers, governments, and others are taking that they may take to recognize and support family caregivers, which would include all of the things listed on this slide. And last year, the RAISE, the Recognize, Assist, Include, Support, and Engage Family Caregiving Advisory Council delivered its initial report to Congress. It was a culmination of a 2-year multifaceted effort that gathered input directly from family caregivers across the country, and the report provides an overview of many of the issues faced by family caregivers nationwide, providing recommendations for addressing those. The strategy was developed jointly. Ultimately it becomes the National Family Caregiver Strategy, which I'll get into. But that was the strategy was developed jointly by advisory councils. So there's the RAISE Family Advisory Council, and there's also an advisory council supporting grandparents raising grandchildren. That was a separate piece of legislation. So there are 2 advisory councils that have been working hard to get the extensive input from family caregivers, the people they support, other stakeholders. But it wouldn't be possible without the partnerships that are included outside of just the the congressional acts that are leading the way. They really have a fantastic group of partners that really support the work. And this particular, there's partnerships that have been developed to establish a dissemination center. And so not only are we, hearing the issues that are being brought up by family caregivers, but really a way to implement the strategies that are being shared as ways to support family caregivers. So critical partnerships out there, more partnerships to come, but super important to recognize the partners in addition to the folks that are participating on those advisory councils. And it really represents for the first time a broad cross-section of the federal government that has collaborated with that private sector in response to the long-standing national need for a comprehensive system of family caregiver support. It's really the product of comprehensive analysis and input from, we have 15 federal agencies that are participating, but more than 150 organizations representing a range of stakeholders from across the nation. That does build upon the initial report that was delivered to Congress by the RAISE Act and the Grandparents Raising Grandchildren Act. They each gave individual reports to Congress, which resulted in the National Strategy to Support Family Caregivers. And this is something that highlights 350 actions that the federal government will take to support family caregivers in the coming year, and more than 150 actions that can be adopted at other levels of government and across the private sector to build a system to support family caregivers. And family caregivers, we know, who provide that overwhelming majority of long-term care in the U.S. We're currently lacking resources to maintain their health, well-being, their financial security, while they provide that crucial support for others. So this national strategy, which is the first of its kind, are really grounded in 5 main goals, and some of them include, I'm going to list a few of the objectives, but there's obviously way more when we get into these actions. But they're grounded in these 5 goals. The first one being to increase awareness and outreach, which includes objectives such as increased caregiver self-identification and inclusion of family caregivers in state, territorial, tribal, and local planning. The second one is build partnership and engagement with family caregivers. So this would include things like training for professionals on ways to interact with family caregivers and the recognition of family caregivers in various care plans. Third, strengthen services and supports, including things like increased person and family centers, family-centered planning, trauma-informed care, culturally competent services, flexible and accessible respite care, and increased support for direct care workforce. Ensure financial and workplace security. That's number 4 on the list. This includes financial planning specifically for family caregivers. And then finally, expand the data, research, and evidence-based practices. And the 2 previous presentations really highlight the fantastic work which can be translated into interventions to support family caregivers. And there's just so much more. It's really incredible work to see what these folks have done. So family caregivers, they include people of all ages, from youth to grandparents, people with and without disabilities, people providing care from a distance, and people meeting a variety of needs. And until now, there has not been a national approach to recognize and support them. So there's a few examples on these next couple of slides. And caregiving is certainly rewarding, but it can also have its challenges. And when caregivers do not have the support that they need, their health, well-being, quality of life often suffer. Their financial future can also be put at risk. Lost income due to family caregiving is estimated at $522 billion each year. And when the challenges become overwhelming and family caregivers no longer can provide support, the people they care for are often left with no choice except to move to nursing facilities or other institutions to foster their care, which then the cost is typically borne to taxpayers. So the strategy, again, represents the first time broad cross-section of the federal government that's collaborated with the private sector on a response to this long-standing need. I've got multiple screens going here. I'm sorry if I'm choppy. But with the support of the John A. Hartford Foundation, the National Academy of State Health Policy, they created the RAISE Act Family Caregiver Resource and Dissemination Center. And I have sort of brought this up a little earlier, but the two presenters prior also, made it clear, you can do this research, but you have to be able to implement, you have to evaluate. And so we have this beautiful, lengthy strategy that really tries to address some of these massive issues, but you can't, it would just be, sitting on the shelf if we didn't have this dissemination center to develop family caregiving resources for state and federal policymakers, or provide the support to the council and the subcommittee members as they continue to craft policy recommendations, and then convene those experts and thought leaders and to provide that expertise to the council and support states as they develop policies and procedures to support and address family caregiver issues. So another shout out to the fantastic partners that are made available. If you want to see the actual strategy, I've got several links here that are included to the National Strategy to Support Family Caregivers. It just was released. Actually, when Pat and I initially started talking about this presentation, I had my fingers crossed that it would be coming out. And sure enough, they made their deadlines, and they've really done fantastic work to put the various congressional recommendations into one strategy of federal actions and other actions for states, communities, and others to be taking. And then the strategy is supposed to be updated every 2 years. Those updates are going to be based on public input. There's actually an opportunity right now to provide public input to this new strategy that's open through November 30th, and as well as the continued work of the advisory councils, communities, states, and tribes, federal agencies that are developing, implementing, and adapting policies to support family caregivers. And this, the strategy includes those 350 actions. We're given 3 years to kind of take those and do something with them. It also includes some specific actions for states, communities, healthcare systems, long-term support and service providers, researchers, employers, philanthropic organizations, and many, many others to make the various goals a reality. It's going to take all of us. So we're thrilled to finally have the momentum and the attention of Congress, and happy to take questions as we move through the presentation.
Great, thank you so much, Lacey. That's incredibly timely to be hearing about the national strategy. And I mean, I know we'll get to all of this in the chat, but I would just love to get into some of the meat of that, of what we think, from these recommendations, how and which agencies and how we think that could be operationalized. But it's exciting the public comment period is open, and that URL is also in the chat for anyone who wants to see it. So yeah, please do put any of your questions in the chat. But now we will move on to our final speaker. We'll be hearing from a nonprofit organization perspective on evaluating service excellence for diverse clients by engaging a bench of organizational partners. And we'll be hearing from Jaquan Heron, Diversity and Inclusion Manager with the American Academy of Family Physicians.
You almost got it right, Jaquan.
Oh, darn, I was so worried. Okay.
Hey, look, it's okay. No one's called me Jaquan since the 3rd grade, so you're in a good position. Hello, everyone. My name is Jaquan Heron. I am the Diversity and Inclusion Manager. Well, I was the previous Diversity and Inclusion Manager for the Alzheimer's Association, and I currently am here at the American Family Physicians located in Bleakwood. I do appreciate you allowing me to come in your space today, but I'm here to talk about diverse partnerships and working with working with a nonprofit and how that can help us in reaching our diverse populations. I was with the Alzheimer's Association for 3 years, and my job was primarily to bring resources, tools, and support to our diverse populations. And how I was able to do that was through our partnerships. The first thing that I always ask myself is, how do we align for the betterment of the community when it comes to our organizations? And what I did is I often caught myself falling down the KPI hole, those key performance indicators, right? And does that make sense for our long-term, for our communities that we want to serve? And if and when will I get pushback, and will that articulate our numbers versus impact? And I always picked impact, but down the road, it will increase our numbers. So you have to be innovative in your pursuits to provide impact. And sometimes that doesn't always align with the organization that you work for, especially when it comes to DEI, right? And how that looks to leadership. DEI is it's a baby, right? It's a baby in the realm of Alzheimer's research. It's a baby when it comes to Alzheimer's care and what that looks like in our diverse population. So sometimes a lot of our organizations don't quite understand how do we pursue that. And that's always important when it comes to your diverse populations to look for the people who are already on the ground doing the work. I'm sorry, I'm going through my notes. So if you pick the proper partnerships, we will no longer have to worry about how many people you will serve because these organizations are already doing the work. You just have to find the angle. Many times in locating nonprofit partnerships with many organizations tend to find the organization that relates to the community they would like to serve and who would open the door without strain or pushback. Now, we typically do that because it's easiest. And doesn't necessarily mean that it's wrong. And it's always a great start. But we want to, like I said, once again, work with the people who are already doing the work. When I was with the Alzheimer's Association, I worked with organizations such as like MARC or the Wyandotte AAA or Telemundo. And why Telemundo was a very important partnership is because now our millennials are the new caregivers. So they take in information a little bit differently. You think about a young lady that we serviced, her name was Sasha. She was a millennial woman. She was receiving her master's. She also had a young family at home, and she was also a caregiver. So she's going to receive information a little bit differently than someone who is 60 plus, maybe working part-time, and they were able to provide a lot of time to being a caregiver. So how do you reach those people? You think about media, you think about social media, think about your marketing efforts. Do they see themselves in your marketing efforts? You think about your community presence. Where are you at? Where are your office is located? What other organizations? What chambers are you a part of? Those are all very important. Sorry. Now, that all boils down to, do you truly understand the community that you would like to serve and their needs, right? This is a very important question because you can't do anything without seeing what their needs are, and you have to meet them where they are. Where are your organizations placed that you're reaching out to? What does the community that you're trying to serve, where do they congregate? You think about churches with your African-American community, you think about some of your community events, you think about the people that they trust. Caregiving does not look the same that it did 20 years ago, 30 years ago, and of course, 40 years ago, it's all different. And then you have to think about, what is the data? What is the socioeconomic need? What are the resources that they already have in their toolbox? And then what are the cultural barriers? I also tell the story about my grandfather and I, how I was a caregiver for him while he was going through chemo for brain cancer. Now, walking into a health system that does not reflect you, does not understand your culture, and here I am, a child when it comes to my grandfather, and for them, the first thing that came out of the mouth, we noticed that you're not taking your medication. Are you medication seeking just to sell this? Boom, the door was already closed. He no longer wanted to go back. But then also not being able to tell the rest of our family what he was going through. I had to keep that secret. My grandmother and I had to keep that secret because we were always told, whatever happens behind closed doors in our home, you don't let anyone know outside these doors. that was a barrier for him. And unfortunately, to his demise, he ended up dying from brain cancer because we didn't get the care that we needed. For one, because the health system did not reflect him. And then two, because we kept it secret and when we didn't get the resources that we need. If we would have partnered with like American Cancer Society of some sort, we probably would have got the support that we need. And here I am, a college freshman, trying to take this all on by myself. And my grandmother, who was 78 at that time, as you can only imagine, it didn't work out in our benefit. Now, I always leave with this one question. You don't walk into any community organization saying, "Hey, trust us." No, you have to ask yourself, what are you doing that's trustworthy? And that's very important. I know it's a very cliche thing to think about when you go into your diverse populations and you work with your diverse organizations, is that they trust these organizations. They do not trust you, because this organization that you're trying to partner or work with has already put in the work. They've already been there. They already have a community presence, and you're building up to that. So I always say you have to be innovative in your pursuits. You have to create great programming. You have to build, like I say, a reputation in that community, and you have to build a reputation with your caregivers. When I was with the Alzheimer's Association, when I first started there, we had 0.3% of African Americans that we reached before I got there. I don't even know if that's a real number, but that did tell me that, for one, we had a data problem. We weren't taking this information because I can almost guarantee that it was because we didn't feel comfortable to asking people, what did they identify as? And it's the same thing with our LGBTQIA plus community as well. This is a very sensitive subject to some people, and some people aren't empowered to ask these questions like, what are your pronouns? But if we had that information going in, our programming would have reflected that. And that's all I have currently right now. But if anyone has any questions about the Alzheimer's Association, even though I'm not currently there, I'm still very closely attached. So I'm here to answer any questions that anyone may have.
Thank you so much. This has been really a great session. With this, I would love to turn this portion of our talk kind of over to Pat McDonald to kind of co-moderate, but also I would love to take this time to A, thank you all of you amazing speakers, but B, if anybody on the line, wants to come off mute, has a question or a comment, we love to make this very interactive. If anyone wants to speak up, you're so welcome to do at this point.
Well, who knew conversations about caregiving could be so energizing and inspiring, but it really, 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 really was today. I loved everyone's comments, and I am sure everyone listening got a lot out of it. I've been watching the chat, and I liked what you said, Jaime, that you liked the comment about trustworthiness versus trust. Poignant. So please, everyone, please come off mute and ask your questions, poke, prod. Our speakers would love to hear from you. And thanks for dropping ways to reach all of you in the chat there. So questions, please jump in. Oh, I know there are questions out there. Don't be shy about being the first. And I liked what you noted too, Selena, that you appreciated how Jaime and Mariana noted the challenges they had developing and implementing their program. Is there a hand raised? Oh, I see messages. I see comments coming in. Let me see. Someone noted, I like the way you're framing it as a question for yourself. What are you doing to be trustworthy? Right. Kate Elaine notices that, emphasizing the critical role of action for oneself. I liked that too. I liked so much of everything I heard today. Questions for our speakers? And thanks for dropping your contact in too, Lacey. And remember, you can provide input to Lacey's organization on their website, which is also dropped in the chat. Okay, questions going once. Questions going twice. Anyone want to come off mute? All right.